Hi, Dr. Chesnut.
Hi, Darryl. How are you?
I'm good. Hope you are too.
Doing great. Thank you.
Great. And good that you have your uniform on today. Can you tell us what kind of doctor you are, where you practice, and which do you feel more comfortable with me referring to you, Commander Chesnut or Dr. Chesnut?
Oh, well, thank you. So you did mention Commander Chesnut. I am in the Navy, so I'm a Navy urologist, and I'm a urologist that has subspecialty training in oncology. So I'm a urologic oncologist, and my practice primarily has been within the military, as a Navy doctor, a Navy urologist in various settings, both in hospitals, deployed settings, and in very well resourced centers within the DoD, and also in austere environments overseas for other reasons. But I also have my experience in my residency training and in my fellowship training in the civilian practice, and did my urologic oncology fellowship training at Sloan Kettering in New York City, and my residency training at Eastern Virginia Medical School in Norfolk, Virginia. And so now I'm primarily practicing at Walter Reed. I work at the Center for Prostate Disease Research, which is affiliated with the military's medical school, Uniformed Services University. And it's part of the Murtha Cancer Center, which is the only military comprehensive cancer center in the world. And so we focus our efforts within the Center for Prostate Disease Research, or CPDR, on all aspects of prostate disease, from prostate cancer screening and early detection to treatment in the localized setting to long-term treatment and management of high-risk and metastatic disease. So we consider prostate disease research from the cradle to grave, from all ages, from benign diseases to cancers. And so as a urologist and urologic oncologist, a lot of patients call me Dr. Chesnut. Within the military, Commander Chesnut. It depends on what the patients are comfortable with. I'm comfortable with either, as long as I'm appealing to what the patient needs at the time. Some patients are very within the military, or are very rank and structure oriented, and they get a lot of confidence in knowing that their physician has some understanding of their background and training, and being a commander is meaningful in that regard. And other patients just want someone that can be a good doctor that they understand, and so I go either way.
So let's actually get into that aspect of your unique practice around prostate cancer. What I was planning to talk about in about 15 minutes, let's do it now. The idea that, you've got people of rank and walking into your surgery, into your consult room. Some of them will be higher, some of them will be lower, some even level. How does that play out in terms of decision making?
Mm-hmm. Well, it's a good point, because in the military, we're trained with rank and structure, and rank has different ranks have different authorities. The way I describe it is, within the examination room and within the hospital, the doctor and patient relationship is sort of a rank-free zone. And so my goal as a urologist is to take care of the patient, whether they have 4 stars on their shoulder or none, and to make them feel comfortable. Now, sometimes patients with higher ranks have different varying schedules, and there's a lot of behind the scenes things to make sure that we can take care of their specific needs when they may be flying in or out of the country at a moment's notice. But you know what? We have the same issues no matter what rank it is. And at the end of the day, we have somebody with concern for a prostate cancer diagnosis, or a prostate cancer diagnosis, and they have needs that are human needs, and rank-based needs usually go out the window pretty quickly, because it's me and the patient and their family and our comprehensive team. We have nurse practitioners, social workers, sexual medicine experts, radiation therapy experts. Everybody sort of comes together to focus on what do you need and what's your issue and how can we help? Because prostate cancer is different. There are different stages and grades, and treatment recommendations, and it's almost like a snowflake. There may be no right or wrong answer for everybody, but there is a right or wrong answer for each patient. And sometimes the rank of the patient plays into what their needs are at the time, and sometimes not. We try to be very cognizant of that.
Now, within the military, whether it's Navy, Marines, Air Force, or Coast, with any sort of structured corporate setting, there's an expectation of protocols that might or ideally be universally applied. But as our audience knows, as you and I know, and as you just described, it's a snowflake setting. Everybody's different. And it's interesting we're using the word snowflake when there are the political connotations of, and the craziness around it. But the idea of people who have grown up in the military as adults, by the time they get to you, they're 40, 50, 60 years old. They've had a career, and all of that career is predicated on understanding protocol. But there's no real protocol with prostate cancer treatment, or even understanding at what stage, level, and what's appropriate. How do you sort of meet them at that level? How do you help them wrap their minds around that this is not going to be, an order of battle kind of situation?
That's a great point, and I think you do very well to identify that, because that's a big area of anxiety for patients and their families when they come in with a new prostate cancer diagnosis, because they may have talked to Uncle Frank or their neighbor down the street or a cousin that has prostate cancer who says, this is what I had, this is the best thing for you, or this is what I had, don't do this. And oftentimes the idea that there are differences in patient preferences, patient treatment goals, and outcomes, and what is tolerable as a side effect and as a treatment course for one patient may or may not be tolerable or desired in another patient. So all these things come together to the point where there's a little bit of a back and forth, and it's sort of a patient-centered, physician-guided and team-based approach to saying these are the different options, and these are the different implications of these treatment choices on you now, on treatment choices in 3 months, 3 years, or 30 years down the line. And sometimes, particularly for military men, but I think also for all patients, you would almost want someone to say, this is your disease, this is what you do, and take your emotions and thought and ideas out of it, because now that you have inputs and choices and there's no single right answer, there's a little bit of fear that you're making the wrong decision, or you're not emphasizing what you want appropriately. So I always tell patients to come in with an open mind and to think in advance of what sort of ideal treatment endpoints and start points and intermediate points you have, because those are important to talk about, because something that's very important for one man may not be important for another, but by the same token, what's important to you needs to be able to be discussed freely with your team, because the last thing we want is to embark on a treatment course that cures the cancer, but cures the cancer in a way that's not acceptable for you, because there are multiple ways to treat this cancer.
Yeah, and you bring up two interesting sidebar kind of things. One, the team approach. You've had civilian patients in your career as well. Do you think military men have a deeper, more intuitive understanding of what a team approach means, and how does that benefit or hinder their treatment?
I think there are there's certainly some being accustomed to working within the team is something that the military patient and their families are sort of innately understanding of. And so when I say this is part of our team, that's going to be your team, and it's not my team, it's our team, and there's some of the things we have to mention is there is no true protocol. There's no I'm not going to defer to you on certain things that I think are important, and you're not going to defer to the sexual medicine person who has different comments, and everyone sort of comes in on even footing. And I think defer is probably not the right word, but we're not going to overemphasize one thing without sort of getting a full breadth of the understanding of the disease. And so I think just stating that is helpful. And military men and their families are really are so almost team geared. And once you're given permission to be part of the team and an active player in your decision making and treatments, it's very helpful. Sometimes people have to be invited to do that because one of the things I've seen, I think it is more common in civilian patients, but I think in all patients where you come in and there's a deference to what the doctor says or a deference to what certain family members may say. And unless you invite the patient to say, this is our decision together, and I'm not going to go to sleep until you're comfortable, and I hope nobody else will do the same. We're all in this until the end. And when I come in to do a treatment discussion, I'm buying the car and the warranty. So I'm not off the team when you make a decision that involves me or doesn't involve me. And I'm there until the end of the line. That's one of the things that's I think special about the military, because we have the largest sort of health network in the country. And that means that we can follow up with these patients at a military hospital in Hawaii or Korea or anywhere. And it's very easy to have those discussions, which may be a little bit more difficult. And I think was more difficult when I was working in some of the civilian settings, because you move to a different area that has a different insurance area. And then sometimes those communications are not as easy.
Yeah, and there's no concern about paying for things either. I mean, access to care is equal, accessible, and 24/7 for the most part. It's extraordinary. By the way, do you think that equal access to care plays into the reduction of the Black men's disparity issues around prostate cancer? That prostate cancer kills Black men at 2.4 times the rate as white men, and Black men typically present with a higher grade level or a more advanced disease than white men. That seems, I mean, from what I've read, it seems to disappear or sort of come closer to less, to a non-conversation in the military. How does that happen from your point of view?
Well, I think that's an excellent point. And I think it's a point that's not well enough discussed. And that's one of the benefits of the military medical system. And here at the Center for Prostate Disease Research, we have a higher percentage of African-American patients than in a lot of the larger cohorts where you see some of the studies from. And so what we have found is I agree, we are diagnosing prostate cancer at younger age among our African-American patients, and oftentimes at higher stage. But what we find is among an equal access to screening, treatment, follow-up, and all care where cost doesn't come into play, that the differences in survival and outcomes do start to level off. And so I do believe that there is some significant barriers to care that are responsible for this, but there are also some genomic, and proteomic differences between prostate cancers in African Americans and in Caucasian Americans that we are seeing, and we're studying that very actively at our center. And I think that can help target and personalize the treatments for different patients from different backgrounds based on their disease. But the bottom line is, when we have everybody coming to the doctor regularly, and your health is our entire enterprise's best interest, we're finding that those disparities are very much improved.
Yeah. And are there any disparities that are unique to the military?
Well, I think within the military, we don't have any sort of unique disparities, but we do have unique exposures. And so I think one of the things that we are very actively looking into in prostate cancer and in other cancers are what sort of military-induced exposures are related to cancers. A lot of people have heard about the Agent Orange exposures and the risk for bladder cancer or kidney cancer. We haven't seen that in prostate cancer, but that doesn't mean we're not looking. But there are things that we're seeing in some of the younger patients now with burn pit exposures. We're not seeing any increased rates of prostate cancer among those patients, but that's not because we're not looking. We are looking, and that's something that with time will mature. And so One of the things that we do have the benefit of is we can look through the medical record and we can know where someone was deployed and when, and we can help determine if there's any associations and ultimately if that matters for treatment or prognosis. Right now, we don't have that, but that is a very big process as part of our Apollo, which is part of program, which is a larger DOD and Merthyr Cancer Center enterprise, which is looking into just that.
Yeah. And were you deployed near any of these burn pits? Like, have you ever been to Djibouti?
I have, yes. I was in Djibouti, and I've been to the Middle East several times. And then also within the medical role down on humanitarian missions, other parts of the world, particularly in Central and Southern America.
So for those in our audience who have not experienced a burn pit exposure, perhaps their service was during Vietnam era or between, 2000 and Vietnam era. What is a burn pit? What does that exposure smell like? What does it feel like? What do you get on your skin and in your lungs?
Well, it is. It's a. Everybody can recall the smell. It's something that you'll remember. It's a heavy smell, and there can be a fog, and it almost darkens the environment, and a haziness. It's hard to say which is due to the burn pit and which is due to the heat and which is due to the sand and the things. There's a whole bunch of things swirling around. But the fact is, the burn pits were a part of life for much of the conflict in the Middle East. And the things that were burned, we're still learning what sort of impacts that has. And it would be not right to assume there's no impact. It would be probably wrong to overestimate the impact at the same time. But like scientists, we want to look into it specifically and see what are there any metabolites in the prostate that we can determine are related, or in the bladder or other places. And the only way to get there is through science and through effort and recognizing that this is an unknown and not tolerating it an unknown, but looking into it.
Yeah. And how do you think the families of men currently diagnosed who might have been deployed, to Iran, Iraq, Afghanistan, anywhere adjacent to a burn pit, or exposed to jet fuel, or exposed to bizarre lubricants, or nuclear-tipped ordnance and such? I mean, how did the families understand that the service that their men that they love and committed their lives to may have contributed to the current state of cancer?
There is a lot of anxiety and uncertainty to what role these things play in disease states. And sometimes it's very unsatisfactory when a patient will come to me or their family will come to me and say, is this related? And I have to look them in the eye and say, I really don't know, but we're going to look into it. And so I think the important thing to do in situations like this is to for patients and family members to sort of know their military and deployment history and where they were and exposure history, and keep note of that. And I have patients all the time. They bring those with them to appointments, and we record it in the medical records. So when it comes time, should there ever be a diagnosis that may ultimately be attributable to this, we can look back in the medical record, which is part of the military record, and see what associations we have. And that can be important for care in the VA and other places. And I think that's another way to do this for people that aren't going to military treatment facilities in the VA is to report those. And I know there are very good mechanisms to do that. And more information is more information. And so we'll be able to dig through that and figure things out.
Yeah. And we'll talk a bit about treatment opportunities unique to military in a brief moment. But just for now, the idea of families, we've mentioned that, and you've mentioned that a number of times. How do families show up in your consult? How does that play out?
Well, that's a great question, because there's been a little bit of there are some limitations with some family visits due to COVID restrictions recently. However, for patients coming into the clinic particularly with a prostate cancer diagnosis or concerns for this, I actually recommend to bring a family member with you. And so the way we deal with those visits is we have family members come into the room, and we also have some specific counseling and education for family members and the patient together. And that's helpful because when you tell somebody you have cancer, sometimes that's the only thing they'll remember. But their wife or daughter or battle buddy or friend who's there with them will be taking notes differently. And sometimes I'll hear from the wife more than I hear from the patient, or from the daughter more than I hear from the patient, or the son more than I hear from the patient, because they're asking these questions. And it's very helpful because it can be very overwhelming. A lot of new terms that trickle off my tongue because I use them every day. It's the first time they're hearing them, and it's the first time they're going through this. And so we ask them to rely on some of our experience, but also to bring family and to talk about it, because that's the hardest thing. And it's something I've seen even in my own family, but also in patients, is you have a diagnosis of prostate cancer and nobody else in the family knows about it because they keep it to themselves. And so it's helpful to bring a friend or a family member so you can, they know you better than sometimes you know yourself, and they certainly know you better than I can get to know you in a clinical visit and can help us work together for a treatment plan.
Right. And you mentioned that men will sometimes be encouraged or will bring their wives to consults. And, no harm done on what I'm about to say, but many of your patients undoubtedly have husbands or partners.
Exactly.
How does that play out in a prostate cancer consult today in military settings for gay men?
Now, that's a very good point. I want to make sure that that we acknowledge that, because we are seeing, so we're for a long time in the military there was no acknowledgement of gay partnerships or marriage, and that's not the case anymore at all by any stretch of the imagination. And we do have patients, actually homosexual patients, and we also have had some transgendered patients post-surgery who have had prostate cancer. And the approaching of treatment of patients who have either in the military or in life have had a lot of times some, I'm not sure what the right term, traumatic or even discouraged conversations with medical providers due to distrust because of not acknowledging sexual orientation is very important to recognize. And I think just discussing it with a patient and their partner is very important. And so I don't want any patient of any sexual orientation to feel that they're alone. But I would have to agree with the statement. I do feel that many gay patients do feel a little bit more alone than simply due to their experiences within the medical treatment facilities in the past.
Yeah. Thank you for that, and let's hope things improve, obviously, and you're certainly going to be a part of that. So thank you for that. Let's move on to what patients can sort of leverage and tricks of the trade. I mean, because people listening to this are also eager for concrete, how can I get healthier kind of advice? What can, Commander Chesnut tell me that's going to help me get an extra year of life? Mm-hmm. So what do you wish your patients knew to say or do in the settings that you've practiced in?
I think it's important to come to a discussion with a urologist or radiation oncologist or a treatment team of any combination with an attitude, particularly with prostate cancer, that you're coming in as a full and equal partner in the decisions. Because unlike some cancers, for example, you have kidney cancer, there's one treatment, and I can tell you what that treatment is, and we can walk out with your surgery scheduled that day. For prostate cancer, there's an element of equivalence of treatments in different disease stages. And so for localized prostate cancer, many men have the opportunity for active surveillance. Others have opportunities for localized surgery with prostatectomy or with radiotherapy, and there are several different radiotherapy options with ranging from brachytherapy to high dose rate brachytherapy to different fractionations of radiation over different periods of time, sometimes with hormonal treatment, sometimes without. And each of those come with a little bit different treatment related side effects and sort of ways of monitoring disease response based on PSA levels after treatment. And so I encourage men to think about what's important to them with their recovery and to realize that in order to feel confident with your decision 5, 10, or 15 years from now, the studies have shown the best predictor of that is feeling involved and empowered to say, no, this is what I want, this is what I feel comfortable with, and not being sort of a passive sort of receiver of treatment that may be someone else's desire but not yours. So,
yeah.
So specific to that, patients that come in, I want them to sort of think objectively about how is their urinary function now? What would be a tolerable improvement or impact of that in a negative way? Same for erectile function. Other things are just thinking about overall health status and other diseases and treatments and other things that are competing with prostate cancer for impacting your life in a negative way, because treating prostate cancer is my job, but at the same point, the patient may also have other issues with heart problems or diabetes problems or other things that impact their prostate cancer treatment decisions and their long-term goals. So thinking about those are important. And the best thing to do for a patient is to be in the best, we all wish this, but to be in the best shape possible when you have something like this, so you can be, you can tolerate any sort of treatment that we would recommend.
Yeah. And actually the military is probably the only setting for last year where people are more reliably in shape than the rest of us out here for the last year with COVID, gaining pounds every month and such. So is there advantage, disadvantage between VA treatment versus on-base treatment?
Well, I think it's really team dependent. So I would one of the things that we found, and we've done a study that we're working on getting published, is people that are treated for localized prostate cancer at military treatment facilities versus those who have. We didn't study the VA in particularly, but we did study versus those who get their treatment in the civilian network. We found that our prostate cancer patients overall did better than the general public. And there are various reasons for that, one of which you already mentioned, which is the access to care and the access to screening and treatment without impact of costs. And I think the other is the way our system works with the patients and families for follow-ups, which is very easy compared to some networks. But there also is something to be said for the way we treat prostate cancer. We have teams that are dedicated to it. So particularly at our hospital, as an example, we've got prostate cancer is something that when if to do surgical treatment of prostate cancer, we have certain quality metrics and things. And so the only urologists that are doing that are the ones that focus on that. We don't have people that do one prostatectomy or one focal therapy every couple of months. We have people that are doing it every day, day in and day out. And so I think whether the care is provided at the VA or the military treatment facility or the civilian network, the questions are more specific to the team and how well you feel you can interact with the team, not as much specifics of whether you go to hospital A or hospital B. The more pertinent question would be, do I feel like my surgeon or radiation oncologist or rehabilitative team is one that I can work with? And have they met certain benchmarks for standards of care? Because some places have and some places haven't.
Yeah, and military folks can choose doctors much like a civilian patient might.
You can, and there are certain What I would say is there are it depends where you are. So I would give an example. For a while, I was a urologist at Camp Lejeune, North Carolina, and I was the only urologist there. So um, if someone in there had prostate cancer or any other urologic treatment issue, I was the only choice. But that varies depending on location. Whereas here at Walter Reed in Eustis, there are many of us. Similarly, people have that problem if you're in a small town in Middle America where you have choice issues. Now, one of the things we do have is a matter of an example is there's someone that had an active duty person who has prostate cancer who's currently stationed in Italy, and their team reached out, and we're bringing that patient through the military back for treatment here with us in Bethesda because we have sort of the team and the outfit to do everything a lot easier than a smaller one urologist place that doesn't do quite as many of those.
Yeah, and I think there are at least half a dozen people watching this that are surprised as I am to hear that Camp Lejeune, which is huge, and Marines all over the place, only had, I mean, good that they had you, but I mean, there was only one urologist, even just for traumatic injuries and stress-related injuries. I mean,
that's something that did change since my time there. They now have 3, and I think the military realized that, and they moved urologists and providers and teams to where the need is. And so that's one of the things they recognized that there was a benefit to having more people there. And so that's what they did. And so I would encourage patients that are in places like that to ask questions is there someone else that can come here, or can I go somewhere else? And because those options are there if you know to ask for it.
Yeah. So as we wind this down, I'm sure there are civilians and people who are looking at you and your career and thinking like, why are you still in the military? Why not just go out and, get a heated swimming pool with a, more lucrative practice? What is it about your career? What can you tell us that caused you as a young boy to get to where you are now, and today makes you want to remain where you are now?
Well, I think there are some wonderful things about the military, and it's the camaraderie of the patients, the providers, the hospital. We really are one team, and there's nothing better than going into an exam room or an operating room, and everybody there has had shared experiences of deploying, or of some going into harm's way, others staying in large hospitals for longer periods of time. But everybody has that same experience of service to their country and service to their teammates and peers. And I think when I walk into an exam room and I see someone who has given so much for me to be able to have a career where I'm doing exactly what I love: urology, urologic surgery on cancer, surgery on prostates, and managing prostate cancer. It's an opportunity for me to do what I love with the people I love in a system that no system is perfect, but this one really is equal access. And if someone has a need, I don't have to go ask somebody if I can have permission to give this medicine or that one if it's not network. And I don't have any worry about my overhead or costs or overruns. My worry is the person right in front of me and their family and their goals. And if I can't do it, I can find someone that can, or to meet whatever needs they have. So there are certain benefits to practicing what I think is almost like a pure form of medicine, where I don't have to worry about some of those things. I worry about the patient. And it's been very rewarding when I see a patient, whether they are, and I'll just give a couple recent examples, whether they are a very senior officer with 4 stars on their shoulder, or whether they're someone that just wants to get their treatment so they can go back overseas and kick down doors and do what they love. The ability to do that and then to get that postcard back from overseas saying, here I am, look what I'm doing now, when 6 months ago I was a patient of yours, and now they're overseas doing what they feel is their mission and haven't dropped a beat. So it's really a special place to work for these patients in this hospital system. I would do it again tomorrow.
Commander, thank you for taking time today to speak with us. Thank you for taking care of your patients. I hesitate to use the cliche, thank you for your service, only because it's become such a cliche, it's lost meaning, I think. But genuinely, thank you for your service. And thank you for taking care of all the people that you have, who also we thank for their service as well. Hope to see you again soon.
Thank you. And thank you for all you're doing for our prostate cancer patients. Thanks so much.
Thank you. Okay, bye.